Thank you, Alicia, and thanks everyone for joining tonight. I hope you've had an opportunity to look at some of the fantastic content that's been part of our annual conference, which will be going on for the next couple of days. I think it's just a truly remarkable achievement that MGMI has been able to bring together such terrific speakers and such terrific resources for our MG community, albeit in a different format and a different way of accessing it, but it has really been tremendous to see how the MGMI community has pulled together and really put together great content for the benefit of our patients and their caregivers. So tonight I have the opportunity to talk a little bit about ocular manifestations of myasthenia gravis. So symptoms and signs that people experience who have MG that affects their eyes and their vision. I have a little bit of content that I wanted to share with you all just as kind of a foundation for how we think about MG as neuro-ophthalmologists, but I'm hopeful that the bulk of our time can be spent just interacting. So if you have questions about ocular MG or any other symptoms related to myasthenia gravis, I'm happy to answer them. So as Alicia said, my name is Chris Glisson. I'm a neuro-ophthalmologist. I practice at the Mercy Health Hauenstein Neuroscience Center in Grand Rapids and also at Michigan State University in East Lansing. And so in addition to the sort of broad scope of neuro-ophthalmic conditions that we see and treat, a large part of my practice is myasthenia gravis. And as we all know, MG will affect vision in some way for about 80 to 90% of patients. So we do see a lot of ocular manifestations of myasthenia, and I have the privilege of being able to treat patients with those symptoms. So just a little bit of background. Ocular myasthenia gravis is sort of the simplest form of myasthenia. And so by definition, it only affects the eyes, typically eyelids with ptosis or drooping of the eyelid, or double vision because of fatigable weakness of the muscles that move the eyes. By anyone's definition, this is a rare condition, about 10 cases per 100,000. And there tends to be this sort of sex and age dependent distribution. So women will generally develop ocular myasthenia in their 20s and 30s. Men tend to develop it a little bit older in life in their 60s and 70s. But of course, these aren't rules that we see maintained all the time. We see patients outside of these age ranges from time to time as well. Thymoma, which we all know is associated with myasthenia gravis and we presume is the source of the circulating antibodies that cause myasthenic symptoms, we see in about 15% of adult patients. So less commonly than what we see in generalized myasthenia, but still something that we look for. And if it is present, it can be a target of therapy by way of thymectomy. And ocular myasthenia gravis tends to have an association with other autoimmune conditions. So we see ocular myasthenia gravis in patients who have thyroid disease, and this is a really important one because there's a condition called thyroid orbitopathy, where patients with thyroid disease, even if it's well controlled, will have different antibodies that circulate through their bloodstream and cause the muscles around the eyes to become swollen or edematous, and that limits the effective movement of the eyes and can also cause double vision. So sometimes it can be very hard in patients with both conditions to sort out whether it's thyroid or whether it's myasthenia gravis. And we also see an association with both rheumatoid arthritis and with lupus. So anytime we're evaluating a patient who has known or suspected ocular myasthenia, we always want to make sure that we're thinking about the possibility of these other conditions existing concomitantly. So if you've been attending the conference throughout the week, there's been a couple of speakers who've talked about this, but just to kind of reiterate the problem with myasthenia gravis, if you look over here on the left side of the slide, you see a normal neuromuscular junction. And so the way that the normal situation works is that the nerve receives a signal from the central nervous system and releases a neurotransmitter called acetylcholine, which diffuses across this space, which is called the synaptic cleft, and then binds to the muscle cell by way of these receptors that are called acetylcholine receptors. So the nerve secretes the antibody, which diffuses across the cleft, binds to the receptor, and then triggers a muscle activation. In myasthenia gravis, what happens is the nerve works normally. It sends out the neurotransmitter, so the acetylcholine diffuses across the synaptic cleft, but when it gets to the muscle cell, or this area called the postsynaptic membrane, there are these antibodies which block the neurotransmitter from binding, and therefore the muscle can't get activated. So that's why you end up having weakness with myasthenia, because the signal that is supposed to trigger the muscle to act just can't get around this blockade. The other thing that we now know happens, and this is sort of one of the targets of some of the newer therapies for myasthenia gravis, is that over time, this perpetual blockade of the antibodies causes a breakdown in the postsynaptic cell membrane. So you see, instead of these deep convolutions that are just loaded with all of these binding sites for acetylcholine, the postsynaptic membrane eventually starts to get degraded. So there aren't as many sites for the acetylcholine to bind. So there's a problem not only with the initial binding, but also with the decrease in the number of sites that are available to generate that muscle activation. So I like to use this analogy with my patients for understanding both the etiology of the symptoms of myasthenia and also how we can look at different ways of treating the symptoms. So if you think about the neuromuscular junction as a soccer match, the nerve is this player here in red, and what he's trying to do is trying to send a signal, which is the acetylcholine, that neurotransmitter that sends the signal to the muscle, over to the muscle cell to trigger an action potential, in this case, to score a goal. What happens in myasthenia is that there are these antibodies that are getting in the way. So every time the nerve tries to send the signal to the muscle, the antibody gets in the way and blocks the shot. So in order to treat myasthenia, we have a couple of different options available to us. We can either make it so there are more soccer balls than the opposing players can defend against, so the signal ends up getting through. And this is what medications like pyridostigmine or mestinon do. They inhibit the body's natural breakdown of neurotransmitters, so there's more acetylcholine around to overcome the blockade. Or we can simply take out the defenders. And that's what things like steroids and other immunomodulatory medications do, is they sort of reduce the antibodies so they're not around to block the signal from getting to the muscle. So why do we see eyes being affected in myasthenia gravis? Sometimes as the first manifestation and often as the only manifestation. Well, there's a couple theories about why this is. One is that even mild weakness will result in symptoms. So if you think about it, we are conditioned as humans to see just one visual image, to see one picture, even though we have two cameras, if you will. We have two eyes, but the brain has to fuse the image from each eye into one solid picture that we interpret as the world around us. And because of that, if there's even a little bit of misalignment of the eyes, if one eye drifts out or in or up or down relative to the other, even that mild bit of weakness will result in symptoms. It's very disconcerting if your eyes aren't aligned. One of the other theories is that there's a high metabolic activity of the extraocular muscles. So even if you're at rest, say sitting looking at your computer screen, listening to this presentation, you're not moving your arms and your legs very much, but your eyes are moving constantly. And we all know that a hallmark of myasthenia is that the weakness is fatigable. So the more you use the muscle, the more the muscle fatigues and the more the symptoms become pronounced. And so because the eyes are moving all the time, they're likely more susceptible to weakness. We also think that it's possible that the extraocular musculature might be more susceptible to that blockade I talked about. So for whatever reason, the antibodies that cause the symptoms in myasthenia have a greater effect on the eye muscles than they might on other skeletal muscle elsewhere in the body. And we think that there might also be some specific antigens that cause a peculiar autoimmune effect that affects the muscles. And this has really been borne out by some recent research and some new and exciting treatments for myasthenia gravis that we think will be available in the coming months to years. So this is just to remind us of the innervation of all of the muscles around the eye. So there are 6 sets of muscles for each eye that are responsible for turning the eye left, right, up, down, and in moving the eyes in a coordinated fashion so that they stay pointed in the same direction, no matter which way you're looking. And I show this only to point out that this is a very complicated system that involves nerves that are generated from the brain stem, specifically in the midbrain and the pons, that then have to travel up through the brain stem along the base of the brain and then out to innervate the muscles around the eyes. When there is a problem with this system that causes double vision, it almost always follows a particular pattern. So when we examine a patient who's having double vision or who is having difficulty moving their eyes, we can generally tell which nerve or muscle or which part of the brainstem isn't working properly. The difference with myasthenia, however, is that it doesn't really follow any particular pattern. Myasthenia is exceedingly variable, and it can really present with any pattern or lack of a pattern that it wants to. And so if we see a patient with double vision or with a disorder of their eye movements, and it doesn't really map out to any one of these particular cranial nerves or any one of these particular muscles, then that's when we start thinking about myasthenia. The other characteristic feature is its variability. So if we have a patient close their eyes for 15 minutes and the eye starts moving better, and then we fatigue the muscles and we start to notice those symptoms or the difficulty with the eye movements become more prominent, then that's another fairly consistent feature that lets us know that we might be dealing with myasthenia gravis. So as I mentioned, there are 6 muscles that are responsible for moving the eyes around in a coordinated fashion. Most of them are innervated by cranial nerve 3, which we see here in blue. One of them is innervated by cranial nerve 6. That's the lateral rectus that turns the eye out. So if you want to turn your left eye to the left, it's the lateral rectus that does that job. And then the superior oblique muscle, which is innervated by cranial nerve 4, really, for all intents and purposes, has the role of bringing the eye down and toward the nose. So cranial nerve 4 is active when you're doing things like reading, or when you're trying to navigate over uneven terrain or find your way onto an escalator or something like that. So generally we can tell by the pattern of weakness or the particular activity that the patient is having difficulty with, which of these muscles might be involved. However, in myasthenia gravis, as I mentioned a couple of moments ago, that pattern gets completely thrown out. So here's a patient that you can see is looking right straight ahead. And what you notice is she's got a little bit of drooping of her right eyelid. So she has a little bit of ptosis here. And if you really look carefully, you can see that this right eye is turned out just a little bit. And the way to see that is if you look where the light reflex is falling on the pupil. It's right in the center of the pupil on her left eye. In the right eye, it's offset a little bit medially. So what that means is this right eye is turned out just a little bit. When we ask her to look to the left, you can see that that left eye turns out just fine. That right eye sort of gets stuck. It can't come all the way in towards the nose. And when we have her look up, you can see that she can get this right eye all the way up. She completely buries her cornea, so you can't see it anymore. But here in the left eye, you can see that that eye gets stuck a little bit, and you can still see most of the pupil in the iris. So again, this pattern really is consistent with myasthenia, not with any of the deficits of these particular nerve or muscle groups. So the common eye symptoms that we see related to myasthenia, first and foremost, one of the things that I listen for when a patient is referred to me is frequent visits to the eye doctor. And the story here is that patients will get a pair of eyeglasses, the eye doctor says they're the right correction, they go home, they wear them for a couple of weeks, and they really can't see very well. So they go back to the eye doctor checks their eyes again, it seems to be the right prescription, or maybe they make a little change, and sort of that same pattern repeats itself a number of times. And if you think about it, the reason for that is that when you go to the eye doctor and they're checking you for eyeglasses or contact lenses, they always check just one eye at a time. So they very infrequently will look to see how well your eyes are working together. But the problem is, if there's just a little bit of misalignment of your eyes, things are going to look blurry. They might not look overtly double, but it's certainly going to feel like your eyeglasses aren't working, and that's going to take you back to the eye doctor unless someone figures out that it's not your prescription, it's the fact that your eyes just aren't moving together in a coordinated fashion. A droopy eyelid or ptosis is another common feature that we see in myasthenia. And one of the things that's often a confounder to a lot of physicians is that the ptosis can be symmetric or it can be asymmetric. And so we would think that myasthenia is a systemic autoimmune disease. It should affect both eyelids equally, but in fact it often doesn't. And it's very common that one eye is more affected than the other. And then, of course, the feature that is hard to miss is true ocular misalignment, where you can clearly see that the eyes are not pointed in the same direction, and the patient will describe double vision. Again, the hallmark of myasthenia is that the symptoms get worse with fatigue, and so we can leverage that during the examination to help be more certain about the diagnosis. So if we ask the patient to close their lids multiple times, and then we look to see whether the ptosis gets worse, that's a fairly strong indicator of myasthenia. Or if we have the patient look up for a long period of time, usually 60 or 90 seconds. And if you try to do that on your own, it really is very uncomfortable and hard to do because it really tires out your muscles. We're not built to spend all that much time looking straight up. And so if we have a patient do that, and then all of a sudden their eyelid gets droopier, or we can see that they have more double vision or trouble moving their eyes, that's another fairly sensitive indicator that the problem is myasthenia gravis. As I mentioned, there's a couple of different treatments that we use, and we typically start with pyridostigmine or Mestinon, which most patients with myasthenia are going to be familiar with. We really use this as first line, but the dose has to be adjusted based on response. And I say this all the time when I'm talking to patients or other doctors about myasthenia, that this is one of those conditions where one treatment does not fit all. We really need to stay in close contact with our patients and make sure we're making adjustments based on how well they're responding to the treatment, and sometimes based on side effects. As far as ocular symptoms, Mestinon works really well for ptosis. It tends to not work very well for double vision. And so if you have double vision related to myasthenia and your doctor puts you on Mestinon and it doesn't get any better, it's important not to lose hope, because it's not uncommon for Mestinon to not do a lot for double vision. And so what we typically do is move to the next line of treatment, which is oral prednisone or steroids. And again, this may be necessary for improving double vision. My own personal philosophy is to start at a relatively high dose so that we can try to move things quickly in the right direction. But then because there are a lot of untoward effects with high dose long-term steroids, we try to taper that down as quickly as possible to the lowest dose that is effective for resolving symptoms. Beyond that, there's immunomodulatory treatments for refractory symptoms. Most people are familiar with immunomodulating treatments for generalized myasthenia, but in certain cases, we'll use them in ocular myasthenia as well, particularly if there are significant steroid side effects that limit their use. If there's no response to a trial of steroids, or again, if we just can't get a patient down to a reasonable dose of steroids because their symptoms keep coming back, then we'll think about using another immunomodulatory agent, which will allow us to discontinue the steroids. As far as treating double vision, you can certainly ignore the double vision or adapt to it. And there are a couple of scenarios in which this doesn't sound as passive as it might initially seem to be. So the first is that if patients have very activity-specific double vision, so if they don't have double vision doing most of their activities, but they only notice they have double vision when they sit down and watch TV at night, and that's the only time that it bothers them. Well, in that instance, it might not be worth it to them to be on a medication throughout the rest of the day when they're not really bothered. And so often what people will do is they'll just decide to close one eye, or they'll cover one eye with an eye patch, or maybe by putting some Scotch tape over their eyeglasses. And if they only have to do it with a certain activity or at a specific time of the day, sometimes that's all that's required. And then medications, as we talked about, can also be useful, but we generally have to move to things like steroids or other immunomodulatory agents that can help. Things that are usually not helpful are eye exercises. And we hear a lot of talk these days about vision therapy and other sorts of practitioners who will provide various exercises for things about vision that aren't working properly. But with myasthenia, the obvious reason for that is that the more you exercise the muscle, the more fatigued they become, and it tends to make the symptoms worse. We can sometimes think about prism lenses for patients whose eyes are misaligned. So if you look at this little guy here, his eyes are turned in. He has what's called an esotropia. And we put him in prism lenses and his eyes are aligned, and he's immediately much more happy because he's not having double vision and things look a lot clearer. Prism lenses may or may not be helpful in myasthenia, again, because the symptoms are generally variable. So if we put a prism in your glasses that gets rid of your double vision at 6 p.m., the prism will probably be too strong and will end up giving you double vision at 9 in the morning when you would otherwise be asymptomatic. There are some patients who have had ocular myasthenia for a long period of time, and the misalignment of their eyes is fairly stable. And as long as we document that as being unchanging over a period of time and in a variety of different circumstances, we sometimes will try prism lenses to alleviate their double vision, but usually only in that circumstance. And eye muscle surgery, which is another technique that we will sometimes use to realign eyes that are misaligned, often is not helpful in myasthenia, again, for that same reason. It's a variable target, and if it's moving all over the place, it's hard to design a surgery that's going to solve the problem in all circumstances. There are several eye symptoms that may be related to myasthenia gravis, but don't have to be. And I always tell my patients that there's a lot that can happen with your vision, even though you have myasthenia, that might be completely unrelated to the fact that you have MG. So if a patient describes blurry vision, the first and most important question to ask is, does it go away with covering one eye? So remember that most of the visual blur that comes from partially treated myasthenia is due to the fact that the eyes are misaligned. They're just not pointed in the same direction. So if you cover one eye and the blurry vision goes away, then it probably is myasthenia related. If you cover one eye and the blurry vision is still there, it's probably not myasthenia. It's probably something like you need a new pair of glasses, or you have dry eye, or something else that's refractive. But if you're not looking with both eyes, and the blurry vision is still there, it by definition can't be due to the fact that you have ocular misalignment. And the way to remember that is just to think about the minions. So Kevin here has two eyes, and so he can have double vision related to myasthenia gravis. If one of his eyes drifts to the left or the right, he's going to have double vision, and that can be from his myasthenia. Stuart cannot have myasthenia related double vision. He has only one eye, so it doesn't matter if his eye muscles aren't working properly, he's still going to see only one image. And so remember that little trick about covering one eye to see if it stays there or if it goes away. Other eye symptoms that may be related to myasthenia is this feeling of eye strain or fatigue. Again, the muscles can get tired the more they're exercised throughout the course of the day. And so if a patient describes just this feeling that their eyes are strained, or that they're tired, or that they feel heavy towards the end of the day, it certainly may be myasthenia related, but it doesn't have to be. Dry eye is another common thing that we see with myasthenia, but it's not directly due to myasthenia itself. And so this is a picture of the front of the eye under a slit lamp. And we've put a special stain called fluorescein in the eye that causes these dry areas to kind of light up with this green color. And so you can see that this is a patient who has a very dry eye because all this fluorescein is getting trapped on top of their cornea. And that's what's really causing their visual blur. It's not the fact that they have myasthenia. It's important to remember there are eye symptoms that are not related to myasthenia. And the one that is most reassuring is that myasthenia will never ever cause you to lose your vision. So vision may be blurry, it may be double, you may have trouble seeing because you have a droopy eyelid, but there is nothing about myasthenia that will cause you to lose vision. And that's a great reassurance that I always share with my patients, particularly when they're initially diagnosed or if we're having trouble managing their symptoms. So other things to think about is whether your glasses need to be updated. Patients with myasthenia develop other eye symptoms as well. So cataracts, glaucoma, macular degeneration, all of the things that tend to be more prominent as we age. So it's always important to not only think about eye symptoms that are related to myasthenia, but also making sure that you're getting a yearly comprehensive eye examination to monitor for these other conditions. So again, just to summarize what we talked about, symptoms are very common with myasthenia. They're very individual and they tend to be variable. And so it can be challenging for you and your doctor to sort out exactly when you're having symptoms, what situations they're most prevalent in, and how to adequately treat your symptoms. But recognizing that there are a variety of ocular symptoms that can come from myasthenia can help with earlier diagnosis. There are multiple methods of treatment. So we use mechanical treatment like eye patches or eyeglasses and medications, generally steroids or other immunosuppressant medications to help with double vision. And in most patients, the symptoms will improve. Admittedly, it may be difficult to completely resolve all of the ocular symptoms, just given the fact that, again, vision is such an important part of our daily lives, and the visual system does tend to be prone to fatigue because we use it so often. But most patients will significantly improve, and the goal is to try to restore quality of life. And remember that even if you have myasthenia, only some of your vision symptoms are going to be myasthenia related. So it's important to see your eye doctor on a regular basis to look for those other conditions that may be affecting your vision. So Alicia, I think I'll stop at that point, and I don't know if we've had any questions come up in the chat or if anybody has anything that they'd like to talk about.
Thank you so much, Dr. Glisson. We do not have any questions that came up in the chat so far. Let's throw it out there to anybody watching. I had muted everyone, but you all should be able, let's see. I'm clicking on you all, asking you to unmute. Don't feel that you have to if you don't want to, but I'm giving you the option. And feel free to ask Dr. Glisson any questions that you might have today.
Is there anything we can do, do you suggest for the dry eye? Because it does seem to make my double vision worse.
Yeah, absolutely. I think that's a great question, and dry eye will make a number of things worse. Certainly, it will cause your eyes to be less comfortable, which will cause you to work a little bit harder, which will cause your muscles to tire out more easily, and will certainly lead to more double vision. And so making sure to treat the dry eye is really an important thing as a preventative measure that can make other symptoms really easier to manage. So the best thing to do is to make sure that you take frequent breaks if you do a prolonged visual activity for any period of time. And so one of the things we know about how we're wired as humans, that if we're concentrating on something, if we're working at something, particularly something that's up close, we tend to blink less. So if you're sewing, if you're writing, if you're working on a computer, if you're doing modeling, if you're doing any other sort of manual task that requires you to use your vision, you're probably not blinking as much as you should, and that's going to cause your eye to get dried out. So I recommend taking about a 5-minute break for every 30 minutes of activity. Just kind of look away or close your eyes for 5 minutes or do something else, and that will help your tear film to get better refreshed. Also, there's a number of over-the-counter artificial tears that are available. The trick to using those is you have to use them pretty often in order for them to be effective. And if you wait until your eyes feel dry, or if they start to get red or scratchy, or if they start to water a lot, it's probably a little bit too late and you're going to be playing catch up. So what I generally recommend is putting a drop or two in each eye every 3 to 4 hours throughout the day if you're prone to dry eye, which all of us who live in West Michigan are. And that way you can kind of stay ahead of the dry eye and keep your corneas well lubricated. There are prescription eye drops. Some of you might have seen the ads on television for Restasis, and the other one is Xiidra. The secret about those is they are exactly the same thing that's available in the over-the-counter artificial tears, except that they have a preservative in them that helps them stay in the eye longer. So you don't have to use them as often. Each of those are just twice a day. So you get a lot of added convenience based on the frequency that you have to use them. The downside is that that preservative can be irritating to some people. And the other big challenge with the prescription eye drops is that they're very, very expensive, and a lot of insurances will not cover them. So I have to be very careful if I prescribe those, because the patient may go to the pharmacy and find out it's $350 a month, which is, of course, not something that is reasonable. And then there's actually really good evidence. There's been a number of studies that have shown that dietary supplementation with things like flaxseed or fish oil actually helps promote a healthy tear film. So if you're someone who has trouble putting eye drops in, or remembering to use the eye drops all that often, or if it's just not that convenient for you based on your lifestyle, flaxseed and fish oil taken as a dietary supplement can really help as well.
Do you have a certain recommendation on milligrams on that?
No, just really
Okay.
any supplement that's available, any fish oil supplement that you can buy at the health food store is fine. Many of my patients will just, buy some flaxseed and sprinkle it on their oatmeal or on their cereal in the morning, and it really does seem to
Okay.
help.
Thank you. If nobody else has another question, I'll stream in with more.
Yeah, it looks like there's a question in the chat from Esther, so I'll answer that one and then we'll come back to you.
Okay.
So the question is, I've heard that some patients use a lid crutch. Have you worked with this tool? If so, how do they work? So a lid crutch is basically a mechanical device that usually is an apparatus that hooks on a pair of eyeglasses and then pushes back on the eyelid to hold it up in place. And it's usually used for patients who have a severe ptosis that obscures their vision in one or both eyes, and obviously a ptosis that doesn't respond to medication. So the only way to get the eyelid to be open is to use a mechanical device that pushes up on the eyelid so that it stays open. I have not used these a lot, and they've sort of fallen out of favor for a number of reasons. The first and most important reason is that they require meticulous eye maintenance in order to not get into trouble with the eye either getting too dry because you're not blinking, or getting an ulceration on the cornea because you can't blink. And if you think about it, if you're going about your daily life and you get a tiny little speck of dust in your eye, you immediately blink and start moving your eye around to try to get that piece of dust out. If you're not able to do that because there's something mechanical that's holding the eyelid open, that can cause over time a trauma to the cornea. You can end up with an ulceration and ultimately even end up losing an eye if it becomes infected. And so for that reason, they sort of fell out of favor just because of the potential for complications unless the patient is really meticulous about using the lid crutch judiciously and safely. The other reason that they're not used as much anymore is that we have more and better treatments for myasthenia. And so oftentimes, if we can't resolve the patient's ptosis with one medication, we'll continue moving to different medications until we get a good resolution. The other alternative to that is, believe it or not, to have a surgery called a blepharoplasty. Most patients are familiar with that procedure on a cosmetic basis. So if you have a droopy eyelid or if you have a saggy eyelid, you can go to an oculoplastic surgeon and they can do a little nip and a little tuck to move the eye up so it is not as droopy. In patients with severe ptosis related to myasthenia, as long as it's not something that is variable, sometimes an oculoplastic surgeon can do a little bit of a blepharoplasty just to move the eye up enough so that you can see, but you can still close the eyelid. But that's another approach that needs to be undertaken very judiciously, and you want to make sure that your oculoplastic surgeon understands myasthenia, number one, and understands the objective of the surgery so you don't end up getting too much or too little to be effective and putting the eye at risk.
Thank you. Well, thank you for her. Is anybody else there? Well, I can give you a little history on what's going on. And I was wondering if remission is a possibility. I was one of the ones that had a thymoma. Mine was about 5 inches. We did eventually get it out. They surgically removed it after I had to have chemo, radiation, and then somebody was actually able to remove the tumor. And then I didn't even know I had myasthenia gravis. It wasn't until like a month after surgery that I couldn't walk. I thought it was just dizziness and lightheadedness, which ended up being the double vision. I kept going to the eye doctor. And it's just like, and they start fitting me with prisms and more prisms. And then finally I did see a neuro-ophthalmologist and he tested me for myasthenia gravis and it was positive.
Was that a blood test?
It was a blood test, yes. So he put me on the generic Mestinon, and I have prisms, but it doesn't completely go away, and I get the blurriness. You just explained some of this blurriness. I thought maybe just my readers and the prisms weren't working, because I'm constantly having to move my glasses trying to see, and sometimes I can't see at all as far as reading.
Mhm.
Reading is very difficult for me. Lighting, if I go to a department store, grocery store, the lighting really makes it worse. It just takes me a little bit off balance. Does that make sense?
It does, absolutely.
Okay.
With the reading, have you tried that experiment to see whether closing or covering one eye makes any difference?
Well, I do that a lot. I close one eye a lot when
Mhm.
I'm trying to read something, but it's just I can't sit down and read a book. I can't
Yeah.
close my eyes the whole entire time.
But if you do
Um,
close your eyes, the image clears up. Is that right?
Let's see. How can I explain this? It's a little bit better. It's not perfect. I'm still moving my glasses around, but
Mhm.
when I drive with an eye patch. If I'm, just trying to read something at the grocery store, I'll close one eye, or if I'm trying to see something that's small, close one eye, and that does help.
Yeah. Yeah, it sounds like the visual symptoms that you're experiencing are really multifactorial. I mean, clearly, there's a component that's myasthenia related. The variability and the difficulty that you're having with things like driving that require you to wear an eye patch, that really sounds predominantly myasthenia related. But some of the blur that you're having with reading that still persists even when you're closing one eye. As you mentioned earlier, I think there's probably a big component of dry eye to that, and so that's where I would start. Oftentimes, if patients describe that type of symptoms and they're constantly moving their glasses around to try to get things in focus, you're just trying to compensate for the fact that the refraction of your eye is off because there's just those patches of dryness there. So I think I would definitely start there. It's really curious the sequence with which your symptoms sort of presented after the thymectomy.
Yeah.
And there's a lot of I guess conjecture around why that could be. One of them is that we know that patients with undiagnosed myasthenia, just going under anesthesia will sometimes cause the symptoms to come through. And so the onset of myasthenia after any surgical procedure is not unusual. But the one that I think you alluded to earlier, which is the idea of sort of this immune reconstitution. So they removed an antibody producing organ from your body sort of had to compensate for that or make up for that physiologically, and whether that caused sort of a flurry of antibodies would be an interesting question.
Yeah. Okay. Anything I can do about the lighting in stores that bother me? No.
I think I would start with the dry eye piece.
Okay.
If so the way to think about dry eye is, I don't know if you've ever been driving in your car and your windshield is dirty and you can sort of see your way through it, but if you turn so that you're directly driving into the sun, it just refracts through that dirt and it becomes just blinding.
Okay.
So the cornea is the same way. If there's a lot of debris in your tear film, if it's dry or if there's other debris there, if there's a lot of light that all of a sudden is reflecting off of that debris, that's when things can get really uncomfortable.
That makes sense, because when I remove the patch for like a couple seconds, I have clear vision, and then it comes back to double. Yep. Okay, that makes sense.
And can I ask, do you have ptosis as well with your myasthenia? Are your eyelids weak? No? Okay.
No. I think when I went to the emergency room, after the surgery, I thought we didn't know what was going on with me. One of my eyes wasn't closing completely, but that has since, I don't see a droopiness. There might be a little bit of offness that I don't really recognize, but when you do take a picture of me, you could see it. They're off, definitely off.
Yeah, and that's the other thing about myasthenia that can contribute to dry eye is that the way that we refresh our tear film is by blinking. And so if your blinking is weak, or if you're not blinking as often, or if it's inadequate, your tear film just isn't getting refreshed by its natural mechanism. And that's why using the artificial tears can be a big help.
Okay. All right. Will do. Thank you. You've been very informative. Thank you so much.
You're welcome. Thanks for coming.
Thank you.
Was that the last of your questions, for you? I wasn't sure if you had any more.
Um, did he answer about the possibility of remission?
Oh, so do you mean, is it possible for symptoms to just go away?
Yeah, because of having the thymus removed, the thymoma.
Yeah, absolutely. And even without a thymoma or a thymectomy, a certain percentage of patients will have a remission at some point in time. It's very hard to get a sense of what percentage of patients that will be or over what time period. But somewhere between 20 and 40% of ocular myasthenia patients will remit at some point. Their symptoms will just go away. So that's always a possibility.
Okay. I won't do the steroids because I have osteoporosis. So I'm a little worried about that. Oh, goodness.
Dr. Glisson, since she had just mentioned steroids being kind of high risk for her, would she, or if you had a patient who was in that same boat, is that where you'd potentially go and look at something like one of the immunomodulating therapies rather than the prednisone?
Yeah, I mean, that's a possibility. The other thing that I would maybe consider working very, very closely either with the patient's primary doctor or their orthopedist, if there's one involved, would be to see how significant the osteopenia or osteoporosis is, how closely we can monitor it, and then what dose of steroids might be reasonable to try. Again, my goal is always to try to minimize or resolve symptoms with the lowest possible dose. And so if that's, a milligram every day or 5 milligrams every other day, and that's something that doesn't seem to be affecting bone density or any other comorbidity, whether it's diabetes or hypertension or what have you, then sometimes that's something that we will try as well.
Okay.
Again, myasthenia is always a very individualized balancing act until we get a treatment that seems to be effective over the long term.
Okay.
Do you ever, if a patient is presenting with ocular myasthenia, will they ever be put on any sort of like would they be put on an immunomodulating therapy to prevent them from potentially developing generalized myasthenia?
So that's a study that has not been done yet. There have been some studies that have suggested, and again, this is a number of years ago, before we commonly used immunomodulatory agents for myasthenia, that putting patients on high-dose steroids for a long period of time would prevent them from progressing. But many people believe that those studies were inaccurate. And so we're kind of waiting for the study that answers that question as to whether or not immunomodulators as an initial treatment end up being preventative. We just don't know that yet.
Interesting. Do you have any tips for a patient who is trying to find an ophthalmologist, or I know you neuro-ophthalmologists are a little bit more rare, and that's another question here in a second for you. But do you have any tips for patients trying to find an eye doctor that is near them that's going to understand MG, or are there any questions they could ask when they're trying to screen someone as their potential eye doctor?
Well, I think the easiest question is just to ask whether they know about myasthenia or whether they treat patients who have myasthenia. If you can find a large group practice, that's probably your best bet, because they generally end up having one or two individuals that sort of see all of the patients within that practice that have a particular diagnosis. And so you're more likely to find someone who has more accumulated experience just because they're seeing all of the patients with that particular diagnosis. So that's another thing to look for.
Thank you. Or they could potentially maybe inquire, of course, if they have a neuromuscular specialist who they see, who is treating them for their MG, that neuromuscular specialist is probably going to be the one to refer them that way anyway, or that's somebody that they could probably ask for that referral.
Yeah, and more than likely that neuromuscular specialist, just by nature of myasthenia gravis, has an ophthalmologist or an optometrist that they work with to help with the vision symptoms.
Excellent. So could you explain, and you did a little bit at the beginning, but just a little bit more about the training that one would go through to become an ophthalmologist who specializes in neurological conditions?
So you can become a neuro-ophthalmologist by a couple of different pathways. You can either go to medical school and then do a residency in neurology, or you can go to medical school and do a residency in ophthalmology. And then to subspecialize in neuro-ophthalmology, you do a fellowship in neuro-ophthalmology, which is generally a year or two post-residency. There, as you alluded to a bit earlier, Alicia, there aren't many neuro-ophthalmologists around, and so as you might expect, there aren't many neuro-ophthalmology training programs across the country. So the ones that are there tend to be fairly rigorous, and they tend to be at academic centers that really have some really bright, really accomplished people who are very active in terms of research and education in the area of neuro-ophthalmology. So almost by definition, if you are seeing a neuro-ophthalmologist, they are someone who has been really well trained at a really good place. It may be my biased perspective, but I think by definition, they're someone who is really passionate and who has dedicated their life to understanding a very complex set of diseases. So yeah, that's the route to neuro-ophthalmology.
So it sounds like we are fortunate here in Michigan. Here in West Michigan, we have 3 fantastic neuro-ophthalmologists, you being one of them. Is that correct?
Yes, we're very fortunate. You know, we have as many neuro-ophthalmologists in West Michigan as you'll find in any large academic center anywhere in the country. When I was doing my training at the University of Pennsylvania, there were 5, which at that time was the biggest practice, but now they've decreased to 3 and they're holding at that level. So we are very fortunate to have 3 of us in West Michigan, and also some great neuro-ophthalmologists elsewhere in the state, both at Michigan State University and at the University of Michigan.
Excellent. What about just offhand, do you know, like if we have somebody watching this who's in like the Western Upper Peninsula, and so coming to one of those areas that you just mentioned might be a bit of a stretch. Is there somewhere over in the Wisconsin area or someplace like that that they might be able to contact if they were seeking a specialist like you?
Yeah, absolutely. You know, Wisconsin, other areas, points to the west. Most big cities with a university and a teaching hospital are going to have a neuro-ophthalmologist.
Okay. And for anyone tuning in, I know everyone on our call right now live is here in Michigan, but anyone who is viewing this later who wants to learn more about that, do please tune in to, I believe it's Dr. Eileen Antonio's talk. She's one of our West Michigan neuro-ophthalmologists, but she did a talk for us on our conference on telehealth for MG, and she talks a little bit about getting those different visits approved by insurance depending on what state you're in. So that's something to consider too, probably, if you're trying to find certain types of specialists that can service you or serve you based on the insurance you have in the state in which you live.
Absolutely.
Does anyone else have any questions for Dr. Glisson? Well, I would love, well, thank you so much for being here, Dr. Glisson. We appreciate your time and your amazing knowledge and unique background that you're willing to share with us.
Oh, it's my pleasure. Thank you for the invitation.
Thank you very much. I really enjoyed this.
Feel free, for those seeing this live or tuning in tonight after it's uploaded to YouTube, make sure that you join us tomorrow on our event page for a talk on LEMS, or Lambert-Eaton myasthenic syndrome. versus MG, a differential diagnosis that's featuring Dr. Amit Sachdev of Michigan State University. He's their director of neuromuscular medicine, I believe. And he will be joining us for that talk on LEMS versus MG, and he'll also be with us Friday as part of our conference doing a research update for myasthenia.
Thank you,